Hi, my name is Hannah Norton, and I'm a physical therapist and a current fellow in training with Evidence in Motion's Orthopedic Manual Physical Therapy program. I'm here today to talk to you about the management of whiplash-associated disorders or cervical acceleration-deceleration injuries in physical therapy practice. Whiplash is a disorder that can be difficult to treat due to the broad range of impairments and psychosocial factors that impact the treatment and recovery of these patients. Understanding current concepts in the management of whiplash-associated disorders, being able to evaluate and assess the effects of whiplash, and knowing how to modify treatment accordingly is important in treating these patients effectively. Whiplash injuries are generally considered to be a soft tissue injury of the neck with symptoms such as neck pain and stiffness, shoulder weakness, dizziness, headache, and memory loss occurring, as well as other things. One of the more difficult conditions to treat is whiplash due to its complex presentation and complicating factors. Whiplash is a spectrum disorder ranging from simple to complex. 80% have no lasting problems and recover well. However, the more complex presentations are problematic, and this can include 20 to 42% of the general population that develops chronic pain as a result. Whiplash is a heterogeneous and complex condition with varying degrees of physical and psychological manifestations, as you see here. All of these things are predictive of a poor functional recovery in a patient, so it's important that we screen for these. So what exactly happens in a whiplash injury? According to Chen in 2009, and based on kinematic studies of the cadaver and on volunteers during whiplash-type injury, there are 3 distinct periods that have the potential to cause injury to the neck. In the first stage, there is a flexural deformation of the neck that is observed along with the loss of cervical lordosis. In the second stage, the cervical spine assumes an S-shaped curve as the lower vertebrae begin to extend and then gradually cause the upper vertebra to extend. During the final stage, the entire neck is extended due to the extension moments at both ends. So as we've mentioned, whiplash presents along a spectrum from less complex to extremely complex. According to Elliott et al. In 2009, there are often instances where the same force and direction of impact can result in 2 very different presentations. This indicates that it's not necessarily the level of soft tissue damage that determines the severity or complexity of pain. Because of this, we have had to shift our focus of evaluation and management of patients with whiplash-associated disorders and the classification. These are now being significantly reassessed due to the emergence of research into why pain and dysfunction in some individuals with whiplash-associated disorders spontaneously improve, while in others they don't. Because the mechanisms of whiplash-associated disorders are not reliant on only the initial nature of the injury, it follows that there are underlying mechanisms that occur in some individuals which result in more dramatic changes to the system. Michelle Curatolo in 2004 provides an explanation of the thought behind the process underlying the mechanism of pain development in patients with chronic whiplash-associated disorders. It is thought that after acute injuries, peripheral sensitization can occur due to the increased nociceptive input from the region of the local injury. Prolonged nociceptive input may result in plastic changes within the spinal cord, resulting in loss of inhibitory capability of the central nervous system in regulating the peripheral inputs being received from the injured tissue. This can cause changes in the supraspinal mechanism of the brain, resulting in an altered perception of input from the injured region and the sensation of pain long after the initial injury has healed. So how does this fit into the treatment-based classification for neck pain? Considering the underlying mechanisms of those who suffer from chronic pain associated with whiplash-associated disorder, the classification system has evolved to encompass the presenting symptoms as well as the associated psychological factors that arise and must be considered for treatment in these individuals. So the pain control classification for the treatment-based classification for cervical spine is defined as Childs et al. Put it here. High pain and disability scores. They have a very recent onset of symptoms. Symptoms are precipitated by a trauma. They have referred or radiating symptoms extending into the upper quarter, and they have poor tolerance for examination in most interventions. For simple presentations, patients with whiplash likely fall under the treatment-based classification for pain control as described here. This model helps us guide treatment and is designed to give the best opportunity for improvement by allowing one to focus interventions appropriately. For others with more complex presentations of whiplash-associated disorders, initial treatment falls into the same classification. However, persistent whiplash-associated disorders is additionally associated with psychological effects, distress, etc., which should result in a modified treatment approach to consider the influence of those factors on the patient's presentation and prognosis. The Quebec Task Force has proposed a classification or a grading system for those with whiplash that acknowledges the other factors that are present that might need to be addressed. For type 1, they exhibit neck complaints with stiffness or tenderness in the neck region and no physical signs of injury. For type 2, they have neck complaints with stiffness or tenderness and some physical signs of injury like point tenderness or trouble turning the head. For type 3, they have neck complaints with stiffness or tenderness and neurologic signs of injury, such as changes to reflexes or weakness in the arms. And then with type 4, they have neck complaints with a fracture or dislocation of the neck. So there are many factors to the evaluation of whiplash-associated disorders from the physical therapy scope of practice. The first part of any examination is a subjective evaluation. The effects of whiplash include assessment of impairments like range of motion, strength, proprioception, joint mobility, etc., as well as psychosocial factors and other components like central sensitivity. We are attempting to identify whether the patient is at risk for developing persistent symptoms or is in the midst of persistent symptoms, as this is key in proper assessment and treatment. So your evaluation should assess for certain psychosocial factors utilizing the tools that you see here. There's the Tampa Scale for Kinesiophobia, Fear Avoidance Beliefs Questionnaire, the Impact of Events Scale. Now this scale does measure post-traumatic stress symptoms and is a predictor or a screen. It's important to remember that post-traumatic stress cannot be diagnosed until at least 1 month following a motor vehicle accident, and this diagnosis is outside the scope of physical therapy practice. However, a moderate level of acute post-traumatic stress syndrome in the screen is considered significant in this population. We've got the Global Health Questionnaire, that's 28. If the patient scores above a threshold of 23 or 24, they're considered at risk. And then the S-LANS, it measures neuropathic pain. A score of greater than 25 is indicative of neuropathic origin of symptoms. Other disability measures that are commonly used for patients with neck pain can also be appropriately used for patients with whiplash. These include the Neck Disability Index, where a score of less than 8 indicates that the patient has recovered, a score of 10 to 28 indicates mild pain and disability, and a score greater than 30 indicates moderate to severe pain and disability. The Numeric Pain Rating Scale is another. We're looking at the severity of the pain, and we also want to make sure that we're asking the patient whether the pain is constant or variable. And then we have the Patient-Specific Functional Scale, which identifies specific functional limitations that the patient perceives to be a result of their disability from their neck pain. All of these can be very helpful for the physical therapist assessment of the patient in identifying factors that are important in treatment and the objective examination. So does the objective data that we find support what we saw with subjective screening? That's what question is in our mind. Interestingly, objective data such as X-ray is not necessarily significant for this population. A loss of lordosis on X-ray provides no prognostic value at all. In the physical therapy examination, we are continuing to look for evidence of a complex presentation. Things that we would find that would support this would be central hyperexcitability, which is a marked hypersensitivity to the brachial plexus provocation test. Does the patient exhibit protective posture? Is neck range of motion guarded and painful? Greater loss of range of motion in these patients indicates a greater chance of prolonged recovery. Does the patient demonstrate cold hyperalgesia? Does the patient demonstrate cervical muscle control that is not appropriate for their age and strength? According to a study by Joel et al. In 2007, they used a biofeedback unit to estimate what ranges were within a normal population, and you can compare that to a patient that presents with whiplash. Oculomotor dysfunction is another thing. We want to look for saccades during eye movements while asking the patient to follow your finger placed approximately 16 inches from the patient's face. Then we'll progress that by asking the patient to shift focus from one finger to the other, or we can do the neck torsion smooth pursuit test, where the second test is repeated but the body is rotated 45 degrees to the side. This test differentiates between cervicogenic disorders and vestibular disorders. Now, how well it does this is unclear, but what has been found is that a high percentage of patients with whiplash-associated disorders and dizziness will get saccades in this position. Continuing on with our objective examination, we're looking for shoulder girdle muscle control, assessing for joint position error. Joint position error can be tested if the neck range of motion allows. This test can be performed in supine. The patient is asked to close their eyes and the physical therapist passively rotates their head. The patient, with the eyes still closed, is asked to return their head to a neutral position. In sitting, this is performed with a projection device and a target. The patient sits about 90 centimeters from the wall. The same process in supine is repeated, and the position of the laser pointer can be marked on the target. Normal error at this distance is 2.5%. However, patients with whiplash-associated disorders typically get more like 10% error. We're looking at postural control. We can challenge this by asking the patient to stand in tandem stance. We're looking at manual examination of the cervical spine. However, we might be unable to test this due to allodynia or hypersensitivity, so that is an important consideration to make for these patients. And then, of course, we have our clinical neurologic examination, looking for things like muscle power, reflexes, and sensation. Testing these components of patient presentation not only gives us a good baseline for function, sensitivity, and response, but it helps us to begin to identify potential interventions and prognostic factors that indicate a likelihood for recovery. The purpose of our subjective and objective examination is to help us to form a complete assessment of our patients with whiplash and to identify patients that are at high risk. As we've discussed, there are two basic categories for these patients for those with whiplash-associated disorders to consider from a treatment-based standpoint. We have simple and complex. A consideration of the criterion in the subjective and objective examination and weighing the components of those treatments can help us to identify which treatments would be appropriate. We need to be able to rate the complexity of the patient's presentation and evaluate risk factors for persistent pain so that we can address them as much as possible. We've briefly discussed the Quebec Task Force classification for whiplash-associated disorders. This table identifies the criterion related to the classification process. As you can see, the evaluative criterion gathered during both the subjective and objective examination are necessary to appropriately identify the grade of whiplash. So there are many options for us when deciding what interventions to perform for our patients with whiplash. These include things like exercise therapy, neck collars, prescribed rest, manipulation, mobilization, advice on posture, traction, electrotherapies, local heat or ice, ultrasound, massage, surgical intervention, steroid injections, and pharmacology are even options for patients that we think would benefit from a consultation with a physician. So how do we decide what to do on the physical therapy perspective? For simple presentations, managing the patients with similar techniques as one would use for the treatment-based classification for pain control would be appropriate. We can do strengthening as the patient progresses. Education is key, making sure to reassure the patient that they will recover. Range of motion activities are recommended, with the goal to regain normal range of motion and keep symptoms to a minimum. However, for the more complex presentation, sometimes this requires an interdisciplinary approach. Often, a psychological referral for trauma-focused cognitive behavioral therapy delivered by a psychologist should be commenced based on data by Forbes et al. In 2007. It might be important to refer the patient back to a general practitioner for pain control via medication. Physical therapy should include active movement and exercises within pain limits, gentle manual therapy and modalities such as TENS, advice and encouragement to begin gentle exercises of the neck, and general activity, being careful not to overly provoke symptoms. Kinesthetic training can be used to address joint position error. For example, have the patient practice rotating their head and returning it to neutral with a projection device, sitting approximately 90 centimeters from the wall, tracing figures, and then progressing by changing the base of support. We can do oculomotor training, where we work on eye movements while keeping the head still, keeping the eyes focused while moving the head side to side, or a combination of eye movements and gaze stability. These can be progressed by challenging the base of support, performing with head turned, and changing the background of the target. One can also try to track a mark on the treadmill, varying the speed to make it more difficult or easier. It is important that we defer more intensive rehab like motor and postural control retraining until a psychologist advises that the patient is ready for this. Some specific impairments that exist with patients who have whiplash-associated disorders include postural control deficits, dizziness, joint position error, and balance deficits. All of these factors have been linked to a poorer prognosis and so are important to address from an intervention standpoint. Drescher et al. Looked at the efficacy of postural and neck stabilization exercises for persons with acute whiplash-associated disorders. Postural control exercises can include things like gaze stability, eye-head coordination, and/or head-on trunk relocation practice in isolation. They concluded that there is moderate evidence to support the use of postural exercises for decreasing pain and time off work in the treatment of patients with acute whiplash-associated disorders. There's also conflicting evidence in support of neck stabilization exercises in the treatment of patients with acute whiplash-associated disorders. Provinciali et al. And Revel et al. Found that including eye-head coupling and coordination exercises as a part of a multimodal approach demonstrated improvements in neck pain and joint position error. In this study by Palmgren et al., participants received an exercise program combining manipulation, proprioceptive neuromuscular facilitation, acupressure, and range of motion exercises, intertwined with exercises to improve head relocation accuracy, which was efficacious for patients with non-traumatic chronic neck pain. Patients in the treatment group showed improvements in pain and head repositioning accuracy when compared to a control. There was no difference in cervical active range of motion between the two groups. In this study, Joel et al. Compared conventional proprioceptive training versus craniocervical flexion training. And they wanted to look at the effects of conventional training versus craniocervical flexion training on cervical joint position error in people with persistent neck pain. They hypothesized that this would help to differentiate the mechanisms of effect of such interventions. The study included 64 female subjects with persistent neck pain and deficits in joint position error. After 6 weeks of training at a frequency of once per week, both groups actually experienced significant improvements in joint position error, neck pain intensity, and perceived disability. The results demonstrated that both proprioceptive training and craniocervical flexion training have demonstrable benefit on impaired cervical joint position error in people with neck pain. The results suggest that improved proprioceptive acuity following the intervention with either exercise protocol could possibly be occurring through an improved quality of cervical afferent input or by addressing the input through direct training of relocation sense. So this gives us a good opportunity for our patients who exhibit deficits in those areas from an intervention standpoint. In conclusion, patients with whiplash-associated disorders in general have a good prognosis for recovery. Patients with complex or chronic whiplash-associated disorders require individualized treatment based on the presentation of physical and psychosocial factors. Management of whiplash-associated disorders is varied, but should include exercise, manual therapy, and kinesthetic or proprioceptive training, as well as education to restore function and get these patients back to their optimal level of function. Thank you for your attention. References are to follow.